It's a great pleasure to be nominated and to be joined into the Giants of Cancer Care, having spent the last 44 years taking care of patients with a variety of cancers, but mostly melanoma. It was, I think, a capstone of work, although, to tell you the truth, as I mentioned from the podium there, we are in the midst of an explosion of new therapies for this disease, which once was the whipping child and has become now the poster kid of the oncology community. So I think we have seen as little as 8-9 years ago, time when we had no therapies for metastatic melanoma that changed survival. Now we have 10, and I think we see another couple coming before the end of the year, and 3 or 4 first-in-human trials of the third generation of the immuno-oncologic agents that we think are so potent. So I think it's an exciting time to be in this field. The first was seeing the first immunotherapy really work in 1984 when we began the first trials of interferon. We did so by gosh and by golly, and we basically hoped that these therapies, which worked somewhat in metastatic disease but were never approved there, would have a benefit to prevent relapse, prevent death of patients who were operable but had still a high risk, residual risk of relapse. So that was clearly the start of a direction that has continued to the present. I think the second big milestone was the understanding of how that first treatment worked using those neoadjuvant treatment approaches I mentioned to you. Because until we looked at the tissue before and the tissue after, we couldn't ask what was happening at ground zero. But once we saw that, it was very clear that this was an immunotherapy. So I think the number of things that impinge on that immune dialogue between the tumor cell and the host immune army is now so broad, including metabolic factors, the microbiome, many factors that we really need to harness, but first need to understand before we can harness them to the advancement of treatment and the advancement of cure of our patients.